We have a very tough lady with a L4-5 spondylolisthesis that has some angular hypermobility on flexion extension views. But here's the main reason why she's here in the operating room. Look at the size of that disc herniation. We call that a monster. And look at how much stenosis she has, plus the facet fluid sign that tells us about instability. So we're going to go in there and do a reconstruction, which involves realigning the spine, stabilizing it, and doing a decompression. To do everything, you have to use screws and rods and cages, but we can do that in a minimally invasive fashion. Instead of making a big incision right down the middle and ripping all these muscles apart, you just go in through 2 paramedian incisions using like a small tubular corridor. And you can get in there, you can decompress the canal, you can put a spacer in there, you can realign everything, and then you can put in the screws that way. That way you don't touch the complex in the middle, which is the muscle, tendon, bone complex, critical for dynamic stability and preventing adjacent level degeneration. So we're all hoping for a great result. If everything goes according to plan, she could either leave tonight before midnight or tomorrow after just 1 midnight with a relatively short recovery compared to open surgery. So we're all hoping for the best and wishing her the very best in a speedy and robust recovery. So again, here is an L4-5 spondy with a big disc herniation and severe stenosis. This will be a challenging posterior interbody reconstruction via an MIS-TLIF technique because we have a hypermobile segment. We need to get lots of lordosis, and very likely the opening in the back will be very narrow, whereas the opening in the front will be very large. So we'll use this as an example of how I choose which interbody cage to place, which depends on what the personality of the disc space is after I do the disc release, discectomy, and end plate prep, and the facet release on the contralateral side. That should loosen everything up, and the interbody space will tell me what it wants to look like afterwards. And I want to try to match that interbody space with the closest matching interbody implant. In other words, we make the implant fit the disc space, not the other way around. Kim maneuver to take down the facet osteophytes so the retractor sits flat. Call that the Paul Kim maneuver. Alrighty, the NAV MIS pedicle screw technique. Create the perfect starting point with a 5mm burr, just like it in open surgery. Oh, I love that technique, because it's really the little things that keep you going. This is the pedicle finder, as they used to call it. It basically finds the middle of the pedicle. Can you hold that? Since very good bone. Oh yeah, no I'm not. Yep, when you have the right trajectory, it just pulls the screw down. It's almost brainless. Now I just need power, so I don't break a nail putting this down. You can just go. That's pretty. Oh, I love it when the screws line up so closely that it looks like you have to put in screws on the other side. Love it with a B. Exposing the surgical target site, as they say. And by using these expandable tubular retractors, the surgical corridor is only slightly bigger than the surgical target site. When we did traditional open surgery, the surgical target site was way smaller than the surgical corridor. We started out like really big to see a tiny little area. And that's what made a lot of spine surgery really morbid, because there's a lot of muscle back here. It's very important for stability and pain control. I'm just saying. So we're back to it, Terry. This is the power and beauty of navigation. Now I'm using the rotating shaver to open up the annulotomy window. It's cheating. You can see everything at all times. It's just not fair. But my mama always said, if you don't cheat every once in a while, you ain't trying hard enough. Skinny black too, Terry. The sixth trowel just fell in. This motion segment's really loose. Oh yeah. It's floppy. I like it. We're going to make her so much taller. Going to go up to an 8, and then the expandable trowel. This just fell into. Mallet. All right, putting in the rise cage, and I'm matching it up to what I anticipate the mallet, the interbody space to look like. So this is not a hyperlordotic segment. Ooh, yes. I wanted to use Sable, my favorite, sexiest implant, but I think you don't need a hyperlordotic cage on this particular situation. Oh, it's getting bigger. Doing a gentle reduction. Get that spondy to look more normal, but I don't want to force it because greed is a powerful force. Things don't go well when you force things. Just saying. But the surgery is going beautifully. Woo! Perfect works. That is the most symmetric construct I've made in a long time. I like it. Save that. You get perfect looking x-rays with navigation. That's the one cheating thing that, right or wrong, I'd rather be perfect than not perfect. I'm just saying. Call me crazy. Oh, look at that. It looks like there's only screws on one side. It's so lined up. That's what we call the, should we put in screws on the other side? Yep. Oh, that looks good. She no longer has a spondy. She's probably going to feel tall again. And she's not going to have any leg pain. And her back pain will also get a lot better. Can't ask for more than that. So here is the disc space before surgery. You can see it's collapsed. It's slightly kyphotic with a grade 1 spondy. The posterior annulotomy window is going to be slightly bigger than typical because of this kyphotic posture. But either way, you can see how difficult it's going to be to reconstruct the L4-5 level to a more normal state. But we'll see what happens after I release the disc space, expand it with the serial trials and the expandable trial, and I'll let the disc space tell me what type of interbody implant to put in, rather than trying to force the interbody implant to make the disc space look a certain way. That usually leads to subsidence. So here's what the disc space looks like after we've done a contralateral facet release and a thorough interbody discectomy and release Making sure that I have as much of the disc removed, going all the way out to the anterior annulus, using serial paddle distractors and expandable trials to loosen the disc space sub. You can see that it stays a relatively kyphotic segment, although it's a lot taller. So in this particular instance, one would be tempted to use a lordotic cage to try to get this more lordotic, but my experience has been that if you mismatch the cage to the interbody space, it eventually subsides to what it wants to be in the first place. So I do not want to use a hyperlordotic cage here, but I do want to use a somewhat lordotic cage to try to get some more lordosis. So in this particular case, I'll utilize the rise implant, which is about 15 degrees, sort of, and expands from 10 to 17. It's also a very big disc space. In contrast, the Sable implant will be much more lordotic. There's an 8 degree, which is a real 8 degree, 15 degrees, which looks supra 15 degrees, and crazy 22 degree lordotic implant. But all of those will probably not match up with the interbody space there and cause a lot of subsidence. So now I've got the Rise expandable implant. It starts out at a 10 and goes to a 17. It has a 15 built-in lordotic posture, although it's not quite 15 degrees, and you can still see that there's a slight mismatch. The posterior disc space is gapped right here, whereas the anterior disc space is touching. And with expansion, you can see the bones move. And it's a lot better. Lots of good bone-to-bone contact. Still a little gap there. We'll try to put a little bit of compression here, but I doubt it'll close down. But when she stands up, it'll probably close down even more.
I've been at this neck of driven someplace besides close. That's all I know.
Here is the final construct. That's the AP. I've got the cage in the middle. Screws look really good. And here's the lateral. You can see maybe a slightly greater closing of the back. Now the two end plates at 4, 5, and 5. The end plates of 5 and 4 are now lordotic in posture. And there's no spondy. And I was able to take down that big disc herniation, so I anticipate she's going to get a great result and probably feel in many ways better right away.